All right, let's jump right in. Today, we're tackling a diagnosis that you absolutely have to know inside and out in the ED or ICU, Guillain-Barré Syndrome. Why? Because this isn't some slow-burn neurological puzzle. It's a full-blown crisis that can unfold in hours, and what you do right at the beginning can literally change a patient's entire life.
So here's how we're going to break it down. We're going to follow a patient from the moment they hit the door, piece together all the clues, face down the biggest threats, and lay out the must-do management steps before we wrap up.
Okay, Section 1. Let's set the scene. You're in the middle of a busy ED shift, and your next patient has just been roomed. So you get the story, a 45-year-old totally healthy until they had some stomach bug a couple weeks back. Now today they're feeling weak, and it started in their feet and it's climbing. Your brain should immediately start firing. That pattern, an infection followed by ascending weakness, that is the classic textbook setup for Guillain-Barré, and the clock is officially ticking. So we have our suspicion, but what's really going on here? To unmask this syndrome, you have to understand the enemy. Let's figure out what we're actually up against. Yeah, I know. That's a mouthful, right? Let's just break that down. Acute means it comes on fast. Inflammatory tells you your own immune system is the bad guy here. And the rest of it, demyelinating polyradicular neuropathy, just means the body is attacking and stripping the insulation, the myelin sheath, off of nerves all over the body. And this is how it happens. Think of it like a 4-step train wreck. First, you get sick, maybe a stomach bug. Your body makes antibodies to fight it off. But here's the critical twist. Those antibodies get confused. They see something on your nerves that looks a lot like the bug they're supposed to be fighting. So they start attacking your own nerves. And when that insulation is gone, the nerve signals just can't get through. That's it. That's where the paralysis comes from. And what kicks this whole thing off? Well, about 2/3 of the time, the patient will tell you they were sick about 1 to 4 weeks before this all started. The number one culprit is Campylobacter jejuni from a nasty case of gastroenteritis. But as you can see, it can be a bunch of other common viruses. And even though it's pretty rare, things like a recent surgery. So, when you walk in that room, what red flags are you looking for? The hallmark is weakness that's the same on both sides, climbing up the body. But listen, the absolute, universal, cannot miss finding is lost reflexes, areflexia. If you're tapping their knees and getting a good kick, you really need to question this diagnosis. And don't forget to ask about pain. It can be severe, and keep a close eye on their vitals for any signs their autonomic system is going haywire. Okay, now we're getting to the part of this that can kill your patient. This is the absolute can't-mess emergency. The reason GBS sends people to the ICU is respiratory failure.
30%. Just let that sink in for a second. Nearly 1 out of every 3 patients with GBS will need a breathing tube. Your job in the ED is to spot the ones heading down that path before they crash and burn.
These right here are your alarm bells. You need to be asking, are they having trouble swallowing? Is their voice getting hoarse? That's bulbar weakness. Ask them, can you lift your head off the pillow? If they can't, their neck muscles are weak. Any of these signs means the diaphragm is probably next on the list to fail. It's time to prepare for an airway emergency. So how do we track this objectively? You need numbers. The best tool at the bedside is serial forced vital capacity measurements. For perspective, a healthy person is somewhere around 70 milliliters per kilogram. The magic number, the danger zone, is less than 20. If you see their FVC trending down towards 20, they are circling the drain. Please do not wait for their blood gas to look bad. That's a late sign. All right, we've identified the high-risk patient. Now, how do we lock in the diagnosis and make sure we aren't getting fooled by a clever mimic? This is where a lumbar puncture is key. You're looking for this classic, fancy-sounding finding, albuminocytological dissociation. All that really means is that the protein in their spinal fluid is sky high, but the white cell count is normal. Think of it as protein without the pus. Here's a crucial pro tip, though. This finding can take a week or 2 to show up, so a normal spinal tap early on absolutely does not rule out GBS. Now, the big mimic you have to rule out is something compressing the spinal cord. How do you tell them apart quickly? It often comes down to the reflexes. Remember, GBS patients have no reflexes. Cord compression, on the other hand, often causes brisk reflexes. Also, if your patient has a clear line on their body where sensation changes, or they have early bowel and bladder problems, you need to be thinking about their spine, not their peripheral nerves. Okay, we're confident in the diagnosis. Now it's time for action. what is our emergency management plan? First rule, do no harm. And this is a big one. If you need to intubate this patient, do not, under any circumstances, use suxamethinium. These denervated muscles have extra receptors that will cause a massive, life-threatening release of potassium into the blood. We're talking cardiac arrest. Just stay away from it. Here's another common trap. You think, hey, it's an inflammatory disease, let's give them steroids. It makes intuitive sense, right? But it's wrong. For GBS, steroids have been shown to not be beneficial and may even make things worse. So the rule is simple: no steroids, period. So what does work? We have to stop the autoimmune attack, and we've got two main weapons for that: IVIG and plasma exchange. The bottom line is they are both equally effective. The choice usually comes down to what's available and easier to administer at your institution. Just remember, there's no benefit to using them both, so pick one and go with it. Finally, where does this patient go from the ED, and what are the absolute must-know points you need to take away from all this? Deciding where they go is all about risk, and honestly, it's not a hard decision. Any patient showing signs of respiratory distress, anyone with severe autonomic instability, rapidly progressing weakness, or any bulbar signs at all needs to go straight to the ICU. There is no room for error here. This is not a patient for a regular floor. Think of this as your cognitive cheat sheet. Just burn it into your brain. When you see a red flag on the left, your immediate action is on the right. Bulbar weakness triggers serial FVCs. Autonomic instability means they go on a continuous cardiac monitor. This is all about being proactive and staying one step ahead of this disease. And this is really the key takeaway. The good news is, the prognosis for most GBS patients is actually quite good. About 85% make a near-complete recovery. But that long journey back, it begins right there, with you, in the ED. Your ability to spot the pattern, anticipate the complications, and act decisively is what sets them on the right path from the very beginning. So you've nailed it. Your GBS patient is stabilized and on their way to the ICU. But the ED never stops, right? What's the next neurological emergency that's about to walk through the door? For more high-yield explainers that get right to the point, make sure you subscribe.